Welcome to AETCM, the Emergency Medicine Channel. Ma'am, shall I start? Present is the case of a 66-year-old male who presented to ER with complaints of lower abdominal pain with inability to pass urine despite the urge to pass urine since 8 hours today. On initial 10-second assessment, the patient was conscious oriented, he was obeying commands, and airway was patent, there was no presence of any pooling of secretions or gurgling sounds. He was able to complete talk in full complete sentences. Breathing saturation was 99% in room air, respiratory rate of 22 per minute, and air entry was bilaterally equal. There was presence of there was no added sounds. Circulation, the heart rate was 100 per minute, and BP of 140/86, and all peripheral pulses palpable. CRT was 2 seconds. Disability GCS was E4, V5, M6, and pupils equal and reactive of 2 mm, and patient was moving all 4 limbs. Exposure temperature was 97.6 degree Fahrenheit, and there was no presence of any rashes. The pain score at that moment was 8 out of 10, and that moment we initially palpated the bladder also. Bladder was distended, so we immediately intervened, and we arranged a 14 French 4 Foley's catheter, and we tried to catheterize, and almost 1100 ml of urine was treated.
So what was this patient's blood pressure?
BP was 140/86.
Okay. What is importance of blood pressure in this scenario?
Usually in patients, there's 2 instances. If patient is in severe distress due to the bladder distension, BP can rise. And the second instance is like if patient after passing catheter, there will be sudden bladder decompression. So sudden bladder decompression can cause hypotension in transient hypotension.
Before inserting Foley's itself, there can be some manifestations. So here you told that the pain score was 8/10. So that pain is one abnormal vital that can happen. Then tachycardia and high blood pressure because of the pain can happen. And if at all the retention is along with the urosepsis, that can cause hypotension. So post-catheterization hypotension is different. So this is before catheterization. Okay.
Yes.
So you told that you have catheterized this patient because of acute urine retention. So what is the thing which you do before putting in Foley's? What all things you will have to take care of?
Initially, we will have to look the bladder status. If there is a USG available, we must look for the bladder.
Bedside
ultrasound to look for the bladder.
Then
next, we must look into the look in the past history also. Like patient is having any presence of any urethric stricture, or patient is having any BPH. What is the pathology underlying is causing, or patient is having any previous spinal neurological pathology. Patient is having an associated constipation.
These are the causes of urine retention. So before that, what you can do is any contraindication is there for putting Foley's catheter in a trauma scenario and all?
Yes, in presence of pelvic trauma, if there is presence of blood through the meatus, that is one of the scenario where we must not catheterize the patient.
Blood in the meatus means we are suspecting urethral injury. Suppose there is no blood in the meatus and nothing like that is there, then is there any contraindication?
Still, if there is presence, high riding positive, when digital rectal examination.
That is when you are suspecting a urethral injury. So urethral injury, because of the suspected urethral injury, we don't want the Foley's catheter to perforate through the urinary tract. That's why we are not inserting a Foley's. That is one contraindication. Any other contraindication other than the urethral injury?
Presence of urethral stricture is actually a presence of like might require like dilated.
That is not a contraindication, especially in RTA. Okay, so if at all a patient is having a pelvic trauma with a huge hematoma over the pelvis, patient's hemodynamics might be preserved because of the distended bladder. This distended bladder might cause a tamboon effect over that bleeding vessel. So if we are putting a Foley's catheter and we are decompressing the bladder, then that tamboon effect will be gone and patient will bleed again, and that can cause a worsening of hypertension. So sometimes this distended bladder will be helpful in this scenario. Okay.
So then after that 1100 ml
Okay,
was
so here we know the problem with this patient, that because of retention, patient can have tachycardia, hypertension, pain and all, and so the treatment is post-catheterization and decompressing the bladder. But what thing we need to consider is that in according to UK guidelines and all, they say that in males, before planning for a post-catheterization, we need to do a what examination? PR exam.
examination.
Why?
To look for prostate and also
Prostate size, consistency, pain.
Also to rule out constipation is associated with it or not.
Mostly constipation will not be as a PR is for the prostate. And in females, we can do a vaginal examination to look for any adnexal mass or anything. But that can be done even after Foley's also. So here we can, our main goal is to decompress. Okay.
After draining the urine, the pain score reduced to 3
so
out
how
of
much
10.
Blood came? Sorry, urine came.
It was about 1100 ml.
Okay. What is the importance of knowing the urine?
Usually the the urine after decompression, if it's more than 600 ml, so it means that we need to retain the Foley's for patient will be having a significant urinary retention. So we might have to retain the Foley's. If there's presence of urine less than 600 ml, patient might not be clinically indicated to keep the Foley's.
Foley's catheter. So, but until and unless we know the cause of retention, we will have to keep the Foley's. Okay. Then, what is the importance of knowing the amount and quality of the urine?
Yes, you should look for the presence of any hematuria is there associated with it or not. Then maybe there will be a presence of a calculi or presence of sediments, which might, and presence of a enlarged prostate. So enlarged prostate, when we insert the catheter, there will be the presence of a hematuria can be normally seen. So that might be the pathology underlying. And
the amount of urine.
Amount of urine mainly depends. It usually tells about the bladder, whether how much the urine draining is draining adequately.
So what is post decompression diuresis?
Post decompression diuresis is that
post obstructive diuresis.
Yeah. Usually after inserting of the Foley's, when the urine drains out, then the next hour we must look for the urine output. The urine output will be higher than usual, and in such conditions we must always supplement the patient with fluids, almost half of the volume of what is the urine output.
So this condition is usually seen in elderly individuals. So if at all a patient is having urinary obstruction and inserted a Foley's, we will see that lot of volumes. Sometimes 1 or 2 liter of urine will come out. Sometimes post obstruction patient will have, the body will have a tendency for diuresis. So all the volume inside the blood will go to the Foley's and will into the bladder and will start draining. So patient will go into hypertension. That hypertension, if it is missed, then that can cause other problems and patient even can we may lose the patient. So especially in elderly individuals, we will have to monitor the next 2-3 hour urine output and see whether the patient is going into post obstructive diuresis.
So we took an adjunct to the primary survey, the pain score had reduced, and CBC CRP showing a total counts of 8,000 with a CRP of 15, platelet count of 1,70,000. VBG we had taken showing a creat of 1.4, no acidosis or alkalosis, and lactate of 1.2. And sample history, the 66-year-old male, known case of type 2 diabetes, systemic hypertension, history of benign prostatic hypertrophy. He was on medications, but he skipped the medication since last 1 week, and he came. He was
for BPH. What all medications?
He was on tamsulosin with finasteride.
What is the role of tamsulosin?
Tamsulosin is an alpha blocker. So mainly it relaxes the smooth muscle,
it relaxes the sphincter area so that the urine will
pass freely. And the presence of finasteride is mainly to the prostate. This action is the prostate receptors.
So tamsulosin is having 2 actions. It is having a action or smooth muscle relaxation action, and also in BPH also it will help. So 2 actions.
And so this patient non-case of type 2 diabetes, systemic hypertension, BPH came to ER with complaints of lower abdominal pain.
Any other medications patient was on? So BPH medicines were there. Was
yes,
patient taking any other medicines?
He was actually non-case of type 2 diabetes and systemic hypertension. So he was on metformin 500 and on Cilaca.
Okay, what is the importance of medication history?
Medication history, there are certain medications which can lead to acute urinary retention. It's usually in various classes of drugs. Usually if patient is on an alpha agonist or a beta agonist, usually sympathomimetic drugs like alpha agonist like presence of ephedrine or phenylephrine, or if patient is taking beta agonist like terbutaline. And if a patient is on any antidepressants, usually amitriptyline or imipramine, and that usually precipitates urinary retention. And antiarrhythmics like quinidine, procainamide, and anticholinergic drugs like atropine, and even patient with presence of hormonal drugs like progesterone, estrogen, and even testosterone supplement drugs can also lead to urinary retention. And also antihypertensives like nifedipine or hydrolysine, they are known to cause acute urinary retention. And miscellaneous drugs like morphine, if given for pain, they can also cause urinary retention. And antipsychotic drugs like haloperidol also known to cause.
So some of the commonly used drugs are antihypertensive, calcium channel blockers, and if at all the patient is taking, that can also cause urinary retention. Okay. So this patient is having a BPH history, so that might be the cause of retention. So what are the causes of other causes of urinary retention?
Urinary retention usually etiology can be classified into 4 groups. Initially it could be maybe due to an outflow obstruction primarily. In males, the most common cause of outflow obstruction is a benign prostatic hypertrophy. Other causes may include presence of a prostate or bladder cancer, or presence of a urethral stricture, urolithiasis, presence of bladder calculi, or presence of phimosis or paraphimosis can also lead to urinary retention. In females, usually there will be pelvic organ prolapse, could be one of the reason of urinary retention, like a cystocele or a rectocele, or a pelvic mass. Or presence of constipation can also lead to urinary retention in both males and females, and or presence of any urethral diverticulum. The secondary, next cause could be mainly the neurological involvement, which could be associated. Patient could be having an incomplete relaxation of the bladder, maybe due to the spinal innervation to the bladder has been affected, mainly in the case of a spinal cord pathology. Spinal cord pathology mainly could be due to a trauma, or presence of an infarct, or presence of an epidural abscess, which may be precipitating the bladder injury. And also presence of demyelinating disorders like presence of multiple sclerosis, Guillain-Barré syndrome, and also presence of diabetic neuropathy can also present with acute urinary retention. And next could be presence of an inefficient detrusal muscle issues. That usually in the case of giving GA or epidural anesthesia, will be without passing an indwelling Foley's, the patient's bladder will be automatically distended. So a distended bladder can further worsen the bladder status of the individual, and patient can present with post-op urinary retention. And then drugs are the main of the other causes, and infection like presence of an acute prostatitis or presence of urethritis, presence of urethral edema can also be cause. And mainly in case of genital herpes. In genital herpes, due to 2 reasons, mainly maybe due to the local inflammation along the site of the urethra, and the second reason could be presence of affecting the sacral nerve. So the herpes will affect the sacral nerve involvement. So neurological involvement can also lead to urinary retention. And also presence of trauma. Trauma is the presence of any pelvic, urethral, or penile trauma can also lead to urinary retention.
So when you are asking in the immediate past history, you need to ask for any recent any urethral procedure that might have led into a stricture, or any history of radiation also should be asked. So that might cause a difficulty in Foley's catheterization. So what if your Foley's catheter is not getting inserted?
Initially we must try, it's told as a standard to try with a 14 to 18 French Foley catheter. If it's not, we are not able to get it through, we can try a like lower size Foley's with a 10 or 12 size Foley's. Even in that Foley's, if it's not getting in, we might require a guide wire and a bar dilator. and that way we must attempt Foley's. If still we are not able to get the Foley's in.
So how will you do with a guide wire and bar dilator?
But like usually we must.
So guide wire is just a
Just a
wire
wire,
only.
yes,
So
yeah.
we can we'll
Insert
have
it
to
to the
apply the lignocaine,
gel.
2% lignocaine gel. Then we can insert the guide wire. So for confirmation whether the guide wire is in position or not, we can use ultrasound and see. Then slowly bar dilator means small size to bigger size dilators are there. So we insert the small dilator first, dilate, and then we will progressively add on with the dilators and we can dilate.
Yes. Still,
if that fails,
we must go for suprapubic cystoscopy.
Cystoscopy is a non-invasive, invasive, but still it will not be a direct approach. So we can plan cystoscopy guided. If at all there is a urology facility, we can plan for a cystoscopy.
If it's not available, we can look for a suprapubic.
How will you do SPC?
In SPC, initially we must clean the first we must shave the around the area, pubic hair and area, clean the area, and initially we must give an incision around the.
Not incision. First we will have to drape the area, suprapubic area. Then we will have to mark the area. Where will you insert?
Mainly in the region.
Suprapubic region. Where? Midline. At least 2 to 3 centimeters above the pubic symphysis. Okay. So if we have an ultrasound facility, we will be very well be able to see. So 2 to 3 centimeters above the pubic symphysis, we will have to see. And how will you direct in? So if the patient is lying down like this, and if the lower limb is here, we will have to approach like this, 60 degrees from the line, from the head end. When you are looking 60 degrees towards the caudally and posteriorly, you will have to direct. So first we will have to use wherever you are planning to puncture, we will have to give local anesthetic. Then we will have to insert 60 degrees from the ground towards caudally and posteriorly. We will have to direct, and we will have to aspirate each time and see. So and while aspirating, within 2 to 3 centimeter, we will be getting the backflow. Okay, and that point, then after finding out the position, then in that area you will have to put a small nick and make that incision little bit bigger, and then we will have to put a obturator along with the Foley's catheter in that same direction. Okay, and once obturator has pierced and the Foley's is inside, then we can dilate the Foley's and remove the obturator. Okay. So that is somewhat a gross technique, especially in ER. So better, safer option is, if at all we have a facility, cystoscopy guided catheter.
And so in this patient, there was no history of any hematuria or dysuria, or no history of any fever. There was history of dribbling of urine and increased frequency to pass urine since the last 1 week. And also there is no history of any back pain. There was no history of any weakness of limbs or numbness along the perineal or perineal region or constipation. There was no history of any recent surgery to the urethra or any abdominal surgeries, intra-abdominal surgeries was not done. No history of any rashes over the body and the perineal region. No history of any trauma to the abdomen and the perineal region. There is no allergic history. There was no allergic history. Medical history: he was on Weltam F tablet and metformin and Silacar. And general examination, the patient was conscious and oriented. There was no presence of any pallor-icterus, cyanosis, clubbing, lymphadenopathy or edema. Per abdomen, post-catheterization was soft, bowel sounds was normal. There was no presence of any, the bladder which was palpable earlier, now it was not palpable. There was no presence of any tenderness or guarding or rigidity. And CNS, there was no presence of any focal neurological deficits. There was no presence of any spinal tenderness. Reflexes were also normal. Power of four limbs were 5/5. And following which we just did the urine routine also. Urine routine of this patient showed 4 to 5 RBCs with 4 to 5 pus cells, and then the presence of bacteria was mildly found. And then USG also was done for this patient.
What all are the maximum investigations that you can do in a retention case?
In the retention case, we can go for the total blood count. We can look, and also look
for infection.
And we can look the blood gas. If chronic urinary retention can lead to presence of a hydroureter nephrosis can further worsen the creatinine. So we can just look into the
for
acidosis.
For renal failure, metabolic acidosis, you can do blood gas. Not necessary. Okay, then CBC to look for infection.
Then after post catheterization,
any other blood test?
And
renal function test can be done. Okay, then electrolytes can be done, especially hypokalemia and all, which can be to know why this happens. So to look for hypokalemia, and a PSA and all is not very necessary in case of acute retention. It will be anyway high only. Okay, so mostly electrolytes and renal function test. Uric acid level also you can send if you are suspecting a uric acid stone. Okay, and a urine routine for looking for any infection. Okay. So, what was done for this patient?
This
Follies was
patient,
catheterized.
Yeah, catheterized, and following which he developed symptomatic relief. Then the patient was we had given for a urology consult, and then he was discharged from the ER to the urology OPD.
So he was discharged to ER to follow up in OPD. Before that, anything else you need to start or restart?
We must restart the medications. The patient was already using medications for benign prostatic hypertrophy. He was on Beltam, but he skipped this medication since last 1 week. So we gave the tablet of tamsulosin with the finasteride, Beltam and.
So alpha blockers, especially tamsulosin, should be restarted. So because one of the most common cause of BPH is urinary retention is BPH. So in such patients we need to start drugs. So what precaution will you ask the patient to before while you are restarting? What precautionary measures will you advise the patient?
Patient can go into postal hypotension is one of the complications associated
because of the drug.
Because of the drug. And
so that should be counseled. Okay. So and this patient was discharged to urology OPD. Okay, suppose a patient is coming to ER who is having a Foley's catheter in situ with a catheter block. Okay, what will you do?
Initially, we must look into the whether there is actually presence of any flow of urine through the catheter or not, through the urobag. And the next thing is we must do an ultrasound. If ultrasound is available in the facility, we must look for the distended bladder, if it's present or not, if there is is there urine present in the bladder or not. Okay. Then if still there is presence of urine in the urinary bladder, we must go for a bladder wash.
Okay, so we need to confirm the presence of urine and we need to look for any sediments or blood clots. So that might be the cause of block. Okay.
Yes. And then we must go for a bladder wash. Bladder wash must be done, and we must try to even after bladder wash, if there's urine not draining out, then we must maybe it may be too.
What if you are not able to do a bladder wash? Nothing is going in the urine. If the entire tube is blocked, what can be done?
They need to change the Foley's. Now it may be a 2-way Foley's. We need to change to a 3-way.
Okay, suppose you are trying to remove the Foley's and you are not able to deflate the Foley's bulb. What will you do?
That ultrasound guided we need to.
When will this happen? So you told that this patient you have inserted the Foley's and discharged. So what is the importance of after inserting Foley's, with what will you inflate the Foley's bulb?
Distilled water, sterile water.
Sterile water. So in some centers, instead of using a sterile water, they will inflate with a normal saline and all. So normal saline is sodium chloride. So that will crystallize inside the bulb, Foley's bulb. And in that scenarios, when you are trying to deflate it, it will not get deflated. So in this scenario, what will you do?
You can use a ultrasound and using a spinal needle, you can just burst the.
As we told, for suprapubic catheterization, you can do an ultrasound, and the suprapubic area you can insert a spinal needle and you can burst the balloon from up. Okay.
Yes. That's all Eunice. And then we can insert it. If patient is having hematuria or severe bladder clots, if we can visualize through USG, that may be the reason of the obstruction. So we can go for a 3-way Foley catheterization.
And continuous drainage.
Can be done.
Okay. Anything else?